is just a cartoon. A small hematopoietic stem cell or a stem cell is asking a professional, well mature cell that I am confused. What should I become? I should become neutrophil, lymphocyte, or any other cell. So even your mature professional person cell also says that even he or she was not aware what he wanted to be. It's just like when you enter a school and then by 12th you come to know ki, what are your aptitude, and then you choose your line. So till your school years you are not aware what you want to do. Though some kind of stimulus or motivation may help you to decide your future. But when you are in nursery or kindergarten, you don't know what you are going to become. You have lots of aspiration till you grow up. So there are adult stem cells also which reside into the particular tissue. So like there are stem cells in dental pulp, there are skin stem cells, heart stem cells, gut maybe stem cells जो crypts में होते हैं, and then skeletal muscles. So these adult stem cells, they will produce cells of same side. They cannot make cells of different types. Okay, so say skin cell will make skin stem cell will make only skin cells. So whenever you these adult stem cells, they basically help in healing if that particular tissue has sustained some kind of injury. So like in liver, even half of it liver you can transplant to the other, and the rest of the healing can happen. Skin damage you see you can heal. Even gut, you have so many ulcerations and all, ultimately it heals. It's just by the virtue of the stem cells of that particular tissue. So now coming back to our topic itself, our hematopoietic stem cell transplant, where we will be using only hematopoietic stem cell. Now these stem cells, they reside in bone marrow, and the area where they reside are called as hematopoietic stem cell niche. Niche is basically place where a person resides or works to its full potential. So like in case of hematopoietic stem cells, these cells, they are they have hematopoietic stem cell niche, which has two parts. One is lining one which lines the endosteal lining, like, and these are the stem cells which are held together by stem cell stromal derived factors, and they are anchored to this osteoblastic lining, and other stromal cells, they also have those factors. They keep this hematopoietic stem cell in quiescent phase and well anchored. And the other niche is just around the blood vessels which are traversing the bone marrow cavity. Okay, and these are actually anchored with stem cell stromal derived factors to their respective endothelial lining. This is bone endothelial lining, this is vascular endothelial lining. Okay. So I will tell you the importance of all these things when we will talk about the process. Okay. So these stem cells in their niche, they continue to proliferate and differentiate, and I mean, it's very interesting to know that the proliferation is so much so that per day 120 billion granulocytes are produced, 200 billion erythrocytes are produced, 150 billion platelets and 20 billion lymphocytes are produced every day. So it is such a rapidly proliferative process, but it is a well organized thing. It all depends upon the body's demand. If you have anemia, your erythrocytic production, this line differentiation lining and proliferation lining will move towards this side, and you will have more of erythrocyte. If you have thrombocytopenia because of any reason, peripheral destruction and all, then again this stem cell will get stimulus and they will proliferate on this line, and then they will further differentiate and more of the platelets will be produced. But these are basically steady state production. Okay, so all hematopoiesis can shift to either direction till the normal counts or normal levels are achieved, or it will continue if the continuous if there is some process which will continue to destroy, or if you are losing somewhere, either in spleen it is getting sequestered. Bone marrow will try to this hematopoiesis will try to produce that particular cell, or if all three cell lines are getting affected and marrow is not defective, this proliferation rate will increase. This slide I'm just showing to give you an idea. This black one is the red marrow, kind of the functional hematopoiesis which occurs in our long bones. At birth, almost all long bones, they have hematopoietic tissues, but as we age, you see by beyond 20 years or so, this hematopoietic tissue, which is red bone marrow, is just confined to the proximal part of your long bones. So the importance you will understand when I talk later about the donor selection part. So before going to the transplant proper, I would just like to know you about the history of bone marrow transplant. It's very interesting to know how the modalities which are available to us have been started decades, or you can say centuries ago, and finally we it is now available to us and we take it for granted. But then lots of work, failures, and have undergone when before this modality is now accepted option for treatment. So this is one very interesting Irish fable. So if you go if you read Wikipedia, somewhere it's around maybe 10 years before Christ, or somewhere between 10 years to 27 years during that period. So during those old days period, people used to fight for prize things, like here they were used to fight for cattle. So particularly they were fighting for a kind of brown bull of Kule, which was found in Kule province only. So now this was a very ferocious war just for possessing that bull. So what happened? This was Siddhan, a charioteer who was a very good warrior, and he sustained very fatal injuries. And because he was one of the favored warrior of the king, so because he was wounded, so king asked 40 doctors to treat this person. 39 of them said no, and all 39 were they were killed. So 40th doctor was stunned, so he was unable to do anything. So then the king sent this person to another doctor who was a faith healer kind of, and in those days those were considered as a doctor, the name of which was Fijil. When he saw his wounds, so he told this person that I can treat you, but it will take 1 year. But if you want to fight, I can treat you, but then you will live only for 4 days only. So it's your option. How do you want to get treated? So this person said that I would choose the other option. So he was made to lie down in a tub bath of full of bone marrow. I don't know what bone marrow, whether it was animal's bone marrow or other marrow, but he was made to sleep in that tub full of bone marrow for at least three days. And after 3 days, he was able to gain sufficient strength, and he fought, and after 5-6 days, he died. So this was the first mention, you can say, kind of people trying use of bone marrow for healing. So then in 19th century, Bob Brown sequered, they used bone marrow to be taken orally after meals, and they found people, anemia getting cured. Basically, from these marrows are probably from animals. So from there, or what they might have got was iron, vitamins, and all such. So their anemia was cured. But so then happened Second World War. Thereafter, there was after atomic bomb explosion. So many people, Japanese condition. So many people were exposed to radiation and had so many fatal illnesses and all. So this, evoked interest in research in tissue repair following irradiation. So there was one scientist in 1957 who rescued 5 physicists who had accidental exposure by infusing bone marrow. In those days, there was no concept of matching and all. They just took bone marrow from different donors and they used, but then they were not able to, there was transient response, that's it. Thereafter, this Mr. Donnell, who is considered as a father of transplant, he treated terminal leukemia patients with their radiation and marrow infusion from a single donor. From a single donor, he infused bone marrow to 6 patients, but all patients died. Obviously, during that time also, there was no concept of tissue matching, conditioning, and prophylaxis of the complications which you can encounter after transplant. So by 1970s, there was data of 200 patients who have received transplant, and almost majority of them had died. So it was kind of bone marrow transplant was kind of written off. But then due to the sustained research and various techniques, now like Hla typing and understanding of the complications of transplant and its management, now ultimately this has become a very, very curative, very important treatment for many of the conditions where it is the only curative option. So for his pioneer work, Sir Donald received Nobel Prize in Physiology and Medicine in 1990. So it's very interesting to know the hard work, failures, which has gone before a treatment modality is available to us. See, 50, 60 years, centuries or decades before people tried this modality. It is not nothing new. Only the techniques are evolving. Even during this time period also, transplant techniques and all, everything is still evolving. So we have not reached to the pinnacle yet. So what are the goals basically which we try to achieve by doing stem cell transplant? Basically, we replace the defective bone marrow stem cells with healthier cells, especially in non-malignant chronic disorders like hemoglobinopathies, aplastic anemias, or immunodeficiencies. And in case of malignancy patients, so we use transplant to repopulate the destroyed bone marrow stem cells, which has happened after receiving high dose therapy and irradiation. So now just we move to how the process of stem cell transplant is carried out. So first we have to see, not everybody will be requiring transplant. Many conditions can be just treated with medications also. So we have to decide where the transplant would be helpful. So there are hematological conditions, mainly malignant conditions like leukemias, and non-malignant conditions like aplastic anemia and autoimmune disorders, hemoglobinopathy. And there are many non-hematological conditions where hematopoietic stem cell transplant is considered as a curative option, like in inborn errors of metabolism or primary immunodeficiencies. So once you have found that, yes, transplant would help this patient, so then you have to decide which kind of transplant. So now there are two types of, basically mainly two types of transplant. One is autologous transplant, which is offered to patients of lymphomas, myelomas, or solid tumors. Autologous transplant, basically that the stem cells are collected from the patient before we take this patient for transplant, but a condition is conditional that the disease should be under control so as to minimize or there should be no contamination of tumor cells. So once the patient has achieved complete remission, then stem cells are harvested and then these are stored, and then the patient is given kind of very high intensity chemotherapy. So with the premise in mind that any microscopic malignant cells which are there in the body, that will also get eradicated under the effect of that high dose chemotherapy. But In the process, bone marrow stem cells, bone marrow stem cells are all bone marrow microenvironment also gets affected. So to rescue the bone marrow, those cells which have been collected before giving the high dose intensity therapy, or also known as the conditioning therapy, these stem cells are reinfused into the patient, and then these cells will repopulate and regenerate the bone marrow again. And this is when the recipient and donor is same. So these are basically done for lymphoma, myelomas. And the other one is autologous, allogenic transplant, which is done basically for leukemias, hemoglobinopathies, anemias, aplastic anemia. Here, the bone marrow itself is defective of the patient. So collecting patient stem cells and giving those stem cells back to the patient who is suffering from defective marrow disease, it is not, a good idea. So you need to give those patients healthy cells which are functional. Okay. So there we take stem cells from a healthy donor of any sex, and after giving high dose therapy to the recipient, those stem cells are infused into the patient. So allogenic is when the donor is different. When we take stem cells from different donor, it's not patient's own stem cell. So now, who all can donate stem cells? You can have, like I told you, in autologous transplant, patient himself is a donor for him, so he is kind of autologous donor. And for allogenic donors, you can find donors in the family, siblings or parents, or if you cannot find donors in family, you can, test for extended family members like grandparents, or if there is a consanguinity in the family. So you can have cousins, other people who can be matched with the patient. So usually we do extended typing in where we get history of consanguinity. And if we are not able to find donor, then we can search a donor in unrelated donor registries. So globally, there are almost 96 registries, which include cord blood registries also, where 39 million donors are registered. Okay? And there are 8 lakh cord blood units lying in the cord blood registries, and we can search donor in these registries. Second, and in India also we have 3-4 registries, and they have also many donors registered with them. Okay. So, but then now we are searching for donor. So the important factors when we are searching for donors, सबसे पहले is HLA compatibility. Why? Because HLA compatibility is basically, I'll tell you, it is kind of tissue, it will tell you about the tissue compatibility. So what is HLA? HLA is basically protein molecule which are expressed over all the body cells, and the body's immune system will identify if those HLA molecules are expressed on the cells. Immune system will find that these molecules belong to our body cell, so will not attack. But a foreign cell or a foreign particle which has a different protein molecules will be immediately identified with the immune cells which are surveilling whole body, and they can find that this cell doesn't belong to my body, so it will immediately kill those cells. So these molecules basically, they are produced by the genes which are present on the short arm of chromosome 6, and this gene cluster is also known as major histocompatibility complex, or simply HLA region. And these have two types of the molecules produced from these genes are basically divided into class 1 and class 2. Like from gene A, these are basically genes. So gene A will produce A antigen, gene B will produce C and B, likewise similar. So these class 1 antigens are produced in almost all body tissues except the RBCs. and also on cytotoxic T cells. Whereas these class 2 HLA molecules, they are basically confined to immune cells. Though T cells can have CD8 and CD4, or B cells, basically they will have class 2 molecules, and other immune cells like macrophages, dendritic, all basically the cells of antigen presenting class. So they have class 2 molecules. This is class 2 molecules are very important. These are the ones which wage immune responses. So this is one example of HLA typing. Now these are from gene A, B, C. These are basically class 1 molecules, A, B, C, DRB1 and D. All these are class 2. So we just, sometimes we just match for 5 genes, A, B, C, DRB1, DQB1, or sometimes we match for 6 locus. So this is, you can see, suppose if, for example, A gene or A antigen, this is fully matched. So likewise, this brother of this patient is fully matched with the patient. So some reports is already mentioned 12 by 12. If it is not mentioned, then you can just match the figures and you can come to know. So there are two types of HLA typing. One is low resolution and the other is high resolution. In low resolution, only you will get these antigens. But if it is further using DNA techniques, you can resolute to further 2-3 digits. This is known as high resolution typing. So this is high resolution HLA typing. So initially, when high resolution techniques were not there, the only matching was done based on antigen level. So then 6 by 6 matching was considered as full matching. So, but then still outcomes, now the outcomes are basically improved, because if the patient, sometimes if the patients are not matched at the allele levels also, this is second digit also. So the chances of various, complication like graft versus host disease or rejections are very high. So the more high resolution typing matching you have, you will have a better outcome. And this is another example where you can see the sister of this patient is just having matching at only 2 loci. Rest, it is not matched. So if this patient is 2 by 12 matched, so we will not consider this donor for transplant. Just to give an idea. So this is the first step when we decide we will take transplant. And this is mainly done for only allogenic patients, not for autologous. Autologous will have it. We don't need to, because it's the same immune system, same cells. Okay. So the importance of matching is shown in this graph. You see, as the number of mismatches increases, the survival also reduces. Say from 60% at 5 years, maybe by 55 to 60% if it is fully matched. Then it goes down further if it is 2 antigen mismatched by 20, 25, 20, 30%. So see, this diagram I have taken from 2007. At that particular time, high resolution matching was not available. Now, gradually, as it is available, everybody is trying to use high resolution HLA typing. So how do we select donor? I have told you the first factor, we have to find out HLA compatibility. Then comes the age. So if you remember the slide I showed about the hematopoietic tissue, so younger the age, more proliferative and good quality hematopoietic stem cells can be obtained. So if we have 3-4 donors for a single patient, so we would like to choose a younger donor for that patient. Okay. And then comes the sex. So same sex matched transplant, they will have a better outcome as compared to sex mismatched, especially if a male recipient is getting stem cells from a female. If she is a unmarried female, it's okay. But if she is a married female, has born 1 or 2 or 4, if she is multiparous, each time she conceives, she's exposed to various antigens of the fetus and she gets illuminized. So already the chances of the recipient, if he receives stem cells from multiparous female, the chances of GvHD graft failure increases. Then CMV is another very, very important issue, because this is one virus which plays, it can cause havoc in a post-transplant course, and we do monitor and we treat also. So it's better if both donor and recipient are negative. This is the best kind of combination. Or if both are positive, that is second best. But if donor is negative, if recipient is negative but donor was positive, then the chances of CMV reactivation is very high, and we have to be on watch. So you need not go into detail. I'm just telling you the importance of CMV, because CMV itself can cause cytopenias and cause lots of complications, which can lead to death also. And then, if again a donor who is pregnant, you cannot take. So whenever we have a female donor identified who is fully matched for a patient, we have to test for the pregnancy. If patient is pregnant, if the donor is pregnant, we cannot take that lady for kind of a donation. And we have to ask for the transfusion histories in all kind of donors. So obviously, anybody who receives transfusion will be exposed to the foreign antigens from the through blood transfusion, and will be alumnus and will cause problems in the recipient who receives. The other important. Am I audible? Am I audible? Shall I?
Yes, ma'am. Yes, ma'am. You're audible.
Audible.
Okay. The other thing which we have to take into consideration is the body weight of the donor as well as recipient. If suppose recipient's body weight is less, but the donor's body weight is kind of high, you can collect. Can you ask that person to unmute himself? So, okay. So if the donor's weight is more than recipient, then it is fine. We will be able to, get good amount of cells even if we do if there is less amount of blood volume. But if the donor weight is very less and the recipient weight is very, high. Suppose a recipient is say 80 kg and the donor is 30 kg. So you will need to process more blood, or if you are collecting from the bone marrow directly, you need to take more bone marrow, and which will not be feasible and will jeopardize the life of the donor. So even body weight has to be taken into consideration. So if we have 2-3 donors fully matched, so then we will take a donor who has kind of almost similar or a higher weight than the recipient. And ABO incompatibility plays less role as compared to in the solid organ transplant, where ABO incompatibility is a big no for transplant. But in cases of our hematopoietic stem cell transplant, ABO incompatibility doesn't matter, except if it is a very it is kind of major ABO incompatibility. We have procedures to minimize the side effects by doing some graft manipulation. So we can do transplant across the ABO compatibility. So the other consideration in donor selection is that suppose there is no non-available. If the match sibling donor is available, donor is with you. You can take, you can start process of transplant early. But if it is not there and you are searching in unrelated donor history, it may take weeks to months also. And it all depends upon the donor's willingness, whether he wants to donate or not. So we have to take all these things in consideration. And if a patient is suffering from such a malignant disorder, which will relapse very early till we are searching for unrelated donor and finding its availability and all, so we can go for alternate donors like haploidentical kind of thing. So there are certain things also which we have to take into consideration, that not always we will go for mass sibling donor transplant, but we can go for alternative donor sources, stem cells also. Just like another source is cord blood also. I'll talk about that later. So it all depends upon the urgency of transplant. If it is a non-malignant condition or which can wait, you can keep on searching for donor till you find a appropriate donor. And it also depends upon that what you want, early engraftment or not. So definitely in immunodeficiency patient, you want especially SCID kind of immunodeficiency patient, those who will die if they don't get transplant within initial few months of their life. So then if you're not able to find match sibling, you go for unrelated donor, not early, then you can go for cord or haploids. And you have to also consider the risk of GVHD. This will depend upon the source of stem cell. I'll tell you later about that also. So, and we have to keep into mind also that patient might require the a second transplant also, because for urgency you are doing one transplant, but there are so many risk factors that this patient might reject. So you have to plan for a second transplant also. And it also depends upon the transplant center's preferences. Like we don't prefer doing cord blood transplant. Cibello doesn't prefer doing cord transplant. And there are worldwide many centers where they use only bone marrow to collect stem cells, not peripheral blood. So it is also transplant center's choice which type of donor and what kind of donors stem cell source they want to use. And some people, they don't do unrelated donor transplant. Very few transplant centers in India do mud transplant also. So, and you also have to keep in mind the type of disease and expected outcome, because you have to tell the patient about the expected outcome. These are just broad ideas to tell them. If the patient, like in leukemias, if the patient is in first clinical remission, matlab patient has not relapsed but is a high risk and has attained remission. So if you do transplant in first remission, the chances of cure are kind of in mass sibling donor is more than 60%. And in unrelated donor, it is again more than 40%. The outcome is basically other complication can happen in mud, so it's less as compared to allo. But then even techniques are now evolving. Even mud and mass sibling donors, they are also having equal kind of outcome. But if the patient has relapsed, any ALL, AML, or CML, who has a chronic phase and again has gone into blast crisis and then again has attained a chronic phase. So in those cases, again, you see the outcome is slightly lower. Okay? And in cases of autologous transplant in lymphomas, outcomes are very good. Some will, even if they have relapsed and again achieved remission, to the tune of 70 to 80% cure rate, you can see. And lesser in DLBCL, because DLBCL is more aggressive. The more aggressive is the malignancies, the more complication and the things are observed. So the outcome are less and chances of relapse are very high. So then we have now selected the donor that we are going to take, this particular donor for transplant. I'm just now talking about allogenic transplant. For autologous transplant, recipient itself is donor. So we do the HLA typing only for allogenic transplant patient. Infectious diseases markers we do for both type of transplant to see if already patient is harboring some kind of infection which can flare up during transplant. We try to treat first those infections and then we take a patient for transplant. And we have to see, these are the routine tests we do for both cardiac issues to see with their cardiac suitability, X-rays just to see any focus of infection, biochemical profile to see whether kidney, liver, they are okay, and coagulation screen. These are just basic. And in case of recipient, we do further or more tests also, apart from these common tests. Like we need to see whether disease in remission, either in leukemias, we do bone marrow to see whether patient has attained remission, or in lymphomas and all myelomas, we do PET scan to see whether patient has achieved image remission in images also. And we do need to do cardiac functional status by doing MUGA, because all these recipients, they have received so much of chemotherapy. And before chemotherapy, we do workup. Then when a patient is newly diagnosed with any kind of malignancy, we do all these tests. Kind of heart is a very important part. So if already this patient has received so many chemotherapy, we know cardiac functions may be, not always, may be compromised. Then we choose our conditioning chemotherapy for transplant according to or we may not take a patient for transplant if if on Muga we find ejection fraction is very low. So as a just mota cutoff is taken as less than 45% or 40%, we consider that the transplant patient is not eligible for transplant, because the heart may not be able to take the stress of chemotherapy followed by transplant, post-transplant complications stress. And in lungs, we have to see the pulmonary function test, chemotherapies or other modalities which are used in conditioning can affect lungs. So if the patient is already having these the problems with the pulmonary function test or chest scan, CT is also showing abnormalities, so we just modify and the conditioning regime, and we may use those agents which will not harm the lungs also. Similarly for kidneys also. And in case of allogenic transplant, when we are doing transplant for congenital disorders like inborn error of metabolism or hemoglobinopathies, so we have to check all those, because those are congenital disorder, hereditary disorder. We have to check those conditions in the prospective donor. That donor may be fully matched and has not manifested a problem by now, by the time that this patient has manifested. So if we are contemplating that a donor for a patient who is suffering from hereditary disorder, we have to rule out those issues in that donor also. Like in thalassemia, obviously thalassemia major donor like intermedia may not be requiring transfusion, and we are thinking, and is fully matched, and we think we can do transplant with that, but we cannot do it, because ultimately thalassemia intermediate patients, they evolve into, they become transfusion dependent as they age. So, but if there is trait is not an issue. It's not a barrier for transplant in cases of thalassemia. We can do trait, because parents are also trait. Parents are living normally. Their siblings are trait. They are living normally. And so many of you might not have got your electrophoresis done. We don't know how many of you are trait also, but you are living normal life. So taking this thing, this corollary in mind, so even in thalassemia, you traits, if it's fully matched, can be taken off as a donor. In cases of Fanconi anemia, it is inherited bone marrow failure syndrome. If you Fanconi anemia can not only present in early childhood, they can present in 30s, 40s also. So you must have seen when we work up for aplastic anemia up to 40 years of age, we ask for chromosomal breakage studies just to rule out Fanconi anemia. So suppose a 20-year-old patient we are trying to transplant from a donor patient is Fanconi anemia and a fully matched donor is brother or sister, we have to rule out Fanconi anemia in that donor also. And similarly, we have to rule out kind of autoimmune condition which can be, transferred to the recipient, because the immune system of that particular donor will be, who is already having autoimmune condition, will be transferred to the recipient. So, and we have to also rule out that the donor is not having some occult malignancies and pregnancies, as I told you. So when we don't have fully matched donor or part donor, then we can resort to haploidentical donors, which is now gradually increasingly used worldwide, because haploidentical donor is available to each and every patient. Like parents are haploidentical, even like their siblings can be haploidentical, and with using different techniques, we can, the outcome of haploidentical transplants are also now nearing just like a massive donor transplant. So this like haploidentical is one haplotype is a big, suppose this is a patient. One haplotype is received from father, one haplotype is received from mother. Now this sibling is fully matched. So in a family, there are 25% chances of sibling being fully matched with a patient. And then these are haplos. You can just see, you can just make a kind of cross thing, and you can see this is also haploidentical, this is haploidentical. And sometime during meiosis, crossover can happen that nothing can be not half match. They may be just like 2 by 12 match I showed you, and there will be no match also. If see this patient, this haplotype from father, and this sibling receives this haplotype from father and mother, and it is not matching with this. So we will not take this patient, this donor because it's not neither haploidentical. So if there is no fully match, we can use haploidentical donor if need arises, especially in basically non-malignant condition. In my malignant condition, sorry. In non-malignant condition, haploidentical transplant is just now being started, but it's kind of still risky, and it's considered as experimental in non-malignant conditions, just like thalassemias, aplastic. But now, gradually, as the data will accumulate, and this will become a accepted type of haploidentical transplant for these non-malignant disorders. So now, after you have chosen the donor and you have found that the donor is fit and all fit to give stem cells, so how we collect the stem cells? Conventionally, initially, bone marrow was the preferred source, and gradually this bone marrow as a source of stem cell transplant is being overtaken by peripheral blood. But still, we do it. There are certain conditions, like in non-malignant condition, where bone marrow is still a preferred source of stem cells. So this is basically a risky procedure in that sense. The risk of anesthesia is there. It is done under GA because you have to do multiple punctures on posterior iliac spine, and since the bone marrow clots very fast, so sometimes you need 2 people to do bone marrow aspiration fast, and at a time you cannot take out more than 2 to 3 ml of bone marrow, and and you are doing rapidly, and you are transferring this syringe to the other person who will be putting all this marrow in this ACD bag. So to collect large amount, so you need more than 2 persons to collect bone marrow, and the whole process may take around 30 minutes to 1 hour, depending upon the weight of the recipient and as well as weight of the donor, because you cannot take out more than 20 ml per kg of bone marrow from a donor. So the other source is basically peripheral blood stem cells, which what we do is we mobilize hematopoietic stem cells from the bone marrow into the peripheral blood circulation, which is done by using growth factors, which GCSF, we say it's short form GCSF, and there are multiple trade names. So you give these growth factor for 4 to 5 days, and on 5th or 6th day, you collect stem cells. So you just see how the counts are rising, and on the penalty made day, we also send peripheral blood CD34 count. If it is more than 10 microliter, we know that patient can mobilize. This donor will mobilize adequately. If the donor can, if it is less than that, then we use another mobilizing agent, which is known as plerixafor. So how do these mobilizing agent work? Is basically, so you are giving daily, and you will see rising count. Those who have worked in bone marrow transplant unit will see how we monitor those cells, and most of the time by 4th, 5th day, we get counts more than 30,000. Anything more than 30,000, you can think of doing apheresis, but provided your CD34 counts in peripheral blood is more than 10 microliter. Otherwise, you can give further GCSF and use another mobilizing agent, and you can do apheresis. Apheresis is basically collecting stem cell from bone marrow through a Efferences machine on next day. So So this is just a kind of flow diagram how GCSF works. GCSF basically doesn't cause proliferation of hematopoietic stem cells. As I've shown you, hematopoietic stem cells, they lie quiescently in their niche when the need arises, and sometimes some of the part of hematopoietic stem cells, they might proliferate under the demand because of growth factors, but mainly the what GCSF does is it will increase, it will cause increase in neutrophils. Neutrophils will produce some enzymes, elastases and all, basically proteolytic enzyme. These enzymes will act on this hematopoietic stem cell. It has the CXCR4 receptor, which is bound to stromal derived factor. I told you initially that they are kept anchored to the extracellular matrix and endothelial lining with the help of interaction between this receptor and stromal derived factor. Now, these proteolytic enzyme will break the bond between these two. So, hematopoietic stem cell will become free from its niche and will move towards circulation. And most of the time, this will we don't need another agent. This will be freely available, freely move and will move into circulation, and we can collect stem cells from efferences. But if it is not good, as I've told you, we have a cutoff. So then we use plerixafor. What this plerixafor does, it will reversibly bind to this receptor. So even if the stem cell has wants to come back and get attached to stromal derived factor SDF factor 1, it will not be able to. So it will be free and it will move towards a blood vessel traversing in the bone marrow and then come into peripheral blood circulation. So this is called as mobilizing hematopoietic stem cell from bone marrow. So by using GCSF, most of the 80-90% of the time, we are able to mobilize only using GCSF. Only in 10-15%, we might require using plerixafor to further mobilize remaining cells, hematopoietic stem cells from the hematopoietic stem cell niche. So this is the Efferences machine. Okay. This is automated. We just feed the weight of the donor and amount of mononuclear cells. Mononuclear cells basically will contain CD34. It's kind of surrogate of CD34. So we just how much we want and what is the hemoglobin of the donor, because all even the CBC of the donor matters while mobilizing. So everything is fed into here by weight, height, CBC, and the volume which we want to fed in this the machine, and accordingly machine will calculate how much volume of the blood from the donor will circulate through this machine to collect that much particular amount of mononuclear layer. So this is the stem cells which gets collected here. That it just looks like a blood. So what are these stem cells? Basically are this buffy coat which are being collected here. Machine is being it centrifuges, and it after centrifugation there is a kit here, so where that the blood from the donor is going inside and it is getting separated into 3 layers, from which only this buffy coat is collected and it goes into the bag. Rest of the RBCs and plasma will go back into the donor simultaneously. Okay, so this whole process is slightly longer than the bone marrow collection. Bone marrow collection, stem cell collection will take only 35 to 40 minutes or 1 hour. This goes on to 4 to 5 hours. So this is one such machine. This is our older machine. The previous one is our new machine. So this you can see. So from one side, the blood is going here and it is going inside this machine. It is getting centrifuged, and this is the anticoagulant which is also flowing inside, so that the blood doesn't coagulate and block the circulation. And an interface of that buffy coat is maintained, and that buffy coat is being collected here, and rest of the plasma and RBC will be again through another route will go back into the patient. It can be done through central line also, or you can use two peripheral line, one inflow, which will blood will go from one side of this one side, and the rest of the blood will come back after the stem cells are collected, and the process will go on for at least 3-4 hours to get adequate amount of collection, and we can send in between the sample to see how much of CD34 which we have been able to collect according to the recipient's age, recipient's weight. Okay, so here donor's weight is basically for how much of volume we can pheresis, but CD34 is calculated according to the recipient's weight. So in between, we can send samples to the hematology lab, and we can get an idea how much more volume we have to efferes till we get an adequate number. Sometimes we may not be able to send, so we do whatever calculation we have got. At most of the time, it is 3 times the blood volume of the donor. Suppose normally a blood volume suppose you can calculate yourself for a 50 kg patient, what plus 60 ml per kg is the body weight, so it will be somewhere around 3 liters, just rough calculation, and 3 times of this blood volume, 3 3s are 9, so we will 9 liters of blood of this donor has to circulate through this machine over 3-4 hours to get maybe 100 200 ml or 300 ml of stem cell harvest product. So we can these are basically unrelated donor stem cells which we have procured from foreign as well as Indian registry, and we have done transplants with mud also. So these are only basically peripheral blood stem cells, and they are brought into a special carrier where the temperature is maintained at 4 degrees. So stem cells can remain viable for at least 24 to 48 hours at 4 degrees also. So if we have to keep stem cell for longer than this, then we have to cryopreserve these stem cells, and we use DMSO, dimethyl sulfoxide, which is a cryoprotectant. This is done in blood bank, and that product can be cryopreserved for months together, or if we preserve in liquid nitrogen, then that product can be cryopreserved for years together. So most of the time we do cryopreservation for autologous transplant in lymphomas when we collect stem cells and we cryopreserve, because after that we give 7 days chemotherapy. So by 7th day, viability of stem cell will be lost. So then we cryopreserve and keep in blood bank, and the day of transplant we thaw and transfuse that product to the patient. And in case of unrelated donor transplant, usually, because if it is coming from far off place and we don't know, some natural disaster happens and we have started already conditioning, or if the donor who is receiving GCSF and on 5th day refuses to come for apheresis, and we have already given patient conditioning chemotherapy, the patient will die if we don't give any stem cells to that. So that is why when we are cautious. So if we are doing transplant, so whenever an unrelated donor product is received, we do cryopreserve and keep it in the blood bank, and then we start our conditioning therapy, and then after conditioning we transplant with after thawing that cryopreserve. The another source is umbilical cord. It is readily available. The only disadvantage is basically the volume is very less. So what happens is when the baby is delivered, from the cord 50 to 200, depending upon the baby's weight and all, you can collect. I mean, the volume can be some as low as 50 or 200 ml, and it is once you clamp, you can collect through, just through needle, and collect in small 25 ml bags, and these units are cryopreserved and stored in private or public cord blood bank for future use. But the only advantage is it is readily available if you have to do an urgent transplant. But the disadvantage is the volume is very less, and there is no risk to donor during collection of cells, because this will be discarded. Okay, but data has shown that those who get their cord blood cryopreserved as has been, I mean, so many celebrities you must have seen in television or in magazines urging you to get your cord blood, baby's cord blood cryopreserved. But the data of various cord blood registries have shown that only 1 in 20,000 person will use that blood as an autologous transplant. Okay, na? So that person will not have any disease during his whole life, then literally is going to get waste. But then you have to pay for cryopreservation and for maintenance also. So even if you are, if you want to cryopreserve, then you have to take into consideration the cost involved. And if you don't need it, then you can donate it to the public cord blood banks, where for smaller babies, where cord blood transplants can be done. And if matching is, if you find a matched cord unit, those public bank from there, public cord blood bank, you can retrieve those cord blood and do a transplant. The only thing where you would, I mean, if somebody asks you, ki, we want to get our cord blood cryopreserved, is we would like not them to, I mean, we will not, encourage, but we will tell only those parents where their earlier child is suffering from kind of a disorder where a transplant is only a curative option, like hemoglobinopathies or in one errors of immunodeficiency and all. But then you have to check whether this cord blood unit, that baby in utero, you can also check whether it is fully HLA match, and as that baby is also not having that congenital problem, then you can cryopreserve that cord blood for that for elder sibling who is suffering from the condition, which is where the option is only transplant as a cure. And then you can use that if the elder sibling is 1 or 2 years, then that amount of matched cord unit is sufficient. But if you the sibling is, maybe 10, 12 years there, or maybe 15, 16-year-old, then you may not be able to use that cord blood. Or sometimes there may be more than 2-3 cord blood units which can be used. But cord blood is not very, cord blood transplants, they are fraught with many other complications. So it's not a very favored kind of source of transplant. And it all depends upon the expertise also of the transplant center, whether they are comfortable doing cord blood transplant. So the difference between the stem cells obtained from the different sources are, I'm showing in this table. Ultimately, it looks like that the peripheral blood as a stem cell source is good because stem cell concentration is good, progenitor content is very high. The only disadvantage is that it has a very high T cell content, which is implicated in kind of graft versus host disease. Chances of tumor contamination if it is allogenic transplant is very less, because we are taking stem cells from a healthy donor. But in cases of autologous transplant, if the disease is not in remission, the tumor contamination, if we are using bone marrow as a source, is very high. And we need a close, as far as possible, full matching is required for bone marrow as well as peripheral blood stem cells. Whereas in umbilical cord, lesser level of matching means a 4/6, 1 antigen or 2 antigen mismatch is also acceptable, because umbilical cord blood stem cells are basically naive cells. They have never encountered any antigens, so they will not be able to mount any GVHD kind of response. But then they have high proliferative capacity, but they engraft also very slowly, because T cells are needed for engraftment, for fast engraftment. So peripheral blood stem cells engraftment is fast, but then GVHD high because of virtue of high T cell content. So fastest engraftment is also seen in, as I told you, is seen in peripheral blood as a stem cell. Bone marrow slightly slower, but it is faster than umbilical. The engraftment is faster than umbilical cord stem cells. Chronic GVHD, again by virtue of T cells, it's highest in peripheral blood stem cells. So for leukemia, if you are using a mass sibling donor, peripheral blood is preferred over bone marrow. But if you are using match unrelated donor, uh, it's kind of similar, but there are chances of more GVHD if you use match unrelated donor. And anti-leukemia effect is if you are using peripheral blood, because what your T cells can provide you graft versus leukemia effect. So then this graft versus leukemia effect is equivalent in unrelated donors, peripheral blood stem cells, or match-related donors, peripheral blood cells. So you can take advantage of T cell contents also. So, but only in malignancies, not in, you don't want any graft versus disease, graft versus host disease or graft versus malignancy effect in non-malignant disorders. So there you would like to have as less amount of T cell, you can deplete that also, or you can use bone marrow as a source, as I've told you earlier, that in hemoglobinopathy, aplastic anemia, younger patients, we would like to prefer bone marrow. But we have to tell the pros and cons, side effects to the donor. Then ultimately it is donor's choice whether he or she wants to go for bone marrow donation or peripheral blood stem cells. So nowadays, even donors and various registries, everybody is now preferring peripheral blood stem cells because least complications, except for GCSF cost, body pains and all, and it is a very safe process. So now, after you have collected the stem cells, you might need to do some kind of graft manipulation or stem cell processing in certain conditions. Like I told you, in case of when you are selecting donors, but if you have a full match donor, but it is major mismatched or minor mismatched, if, minor blood group mismatch or major blood group mismatch, there you can manipulate by, if it is a major blood group mismatch, major means a recipient who is having antibodies against donor. Okay, suppose recipient is O, it will have antibodies against blood group A and blood group B. And if your full match donor is B, so this recipient will have so many antibodies against the donor. The moment if your harvest product is contaminated heavily with RBCs, especially in bone marrow, because bone marrow you are not doing, if you are collecting stem cells from bone marrow, you are not doing any apheresis. You are just aspirating bone marrow, and it will also be having so much of blood also. So their RBC content will be high. And if you are giving that bone marrow harvest product, using that harvest product in ABO mismatched transplant, then RBC, there will be rapid hemolysis of those RBCs in a bone marrow harvest, and that can lead to complication of acute hemolysis. But in cases of peripheral blood harvesting, so hemoglobin content is very low. So there we may not require RBC depletion, but still we look if hemoglobin content of that harvest product is more than 2 or 3, then we will do a RBC depletion of that product also using various, sedimentation technique or centrifugation. It is done in bone marrow. But if it is a minor ABO matched transplant, where the antibodies are present in donor against the recipient, then, and those antibodies are present in plasma, so then you will remove those antibodies by plasma depletion through centrifugation. So we can do manipulation in ABO mismatched transplant so as to minimize the complication. And like I told you, for bone marrow harvest, if it is ABO mismatch, then you do rapid RBC depletion and all. But then, since because we are collecting bone marrow, it will be contaminated with fat as well as some bony spicules also. So those are also filtered. There are special bone marrow harvest filters available, which can filter all these spicules and fat, and then you can use that harvest bone marrow stem cell for infusion into the recipient. And cryopreservation, as I've told you, when you have to keep stem cell harvest product for a longer duration so as to maintain its viability, you use DMSO, and usually we do it in auto and mud, as I've explained earlier. And like T cell depletion is basically done in cases of haploidentical transplant, because if the T cells are very high, they can cause, they can cause complication in the form of GvHD and delayed engraftment. But if you deplete, then because T cells are needed for engraftment also, like T helper cells, they are needed for engraftment, and cytotoxic T cells are the one which causes GvHD. Okay, so if you do T cell depletion, then we have to be prepared for the later graft failure also and all. So then what people do is they give T cell add back. They collect T cells while doing the T cell depletion, and then after a week or so, they give T cells to the patient. But nowadays, it is seen that it is better to use T cell replete. You don't do T cell depletion. You do T cell depletion basically in non-malignant condition where you don't have MASH donor and you don't want any GvHD. There T cell depletion can be done using this machine, which is Clinimax, and it has magnetic beads and all, which coats T cells, and then by virtue of applying magnetic field, those cells are collected in another bag, and rest of the product is collected in the other bag, and you can use a purified form which is devoid of T cell. And people have further modified it, that they don't remove whole of the T cells, because T cell gamma delta T cells are basically kind of, you can say, the good kind of T cells, which which reduces GvHD and helps in fighting infection. But it is the alpha beta type of T cells which are implicated in GvHD. So further refining techniques are used so that only alpha beta T cells are removed. And also sometimes graft cell contains B cells. B cells will produce later on antibodies. So even B cells also can, T cells and B cells, they can be depleted from the product, and you can use this depleted product in haploidentical transplant with good outcomes, especially in immunodeficiency patients and non-malignant conditions. So the processing of product is another thing, and meanwhile that patient is receiving chemotherapy or radiotherapy as a part of conditioning. The idea behind conditioning is to give maximally tolerated doses of multiple agents which have non-overlapping toxicity, and to eradicate the disease wherever in the body it is, bone marrow or lymphoid tissue, or wherever the cells, malignant cells are hiding. And the other benefit of conditioning is it will also immunosuppress the recipient, so that recipient is ready to accept the incoming cells and will not reject it. And the third benefit of doing conditioning is basically it will also, because all cells of bone marrow will, they will be ablated, there will be a space where the incoming cells can find, they can home in, and then they can reside, and then they can proliferate and differentiate in the hematopoietic stem cell niche, which are now emptied by the virtue of using conditioning. So just you do not remember all these things. There are two kinds of conditioning regimens: myeloablative, where you just wipe off the bone marrow of its all cells, and non-myeloablative, where donor hematopoiesis is still there. And in myeloablative, there will be no donor. We presume that there will be no donor hematopoietic tissue left, and it can be irradiation containing, which is TBI based, or it can be non-TBI based. So the advantage of non-myeloablative conditioning regimen is you need lesser dose of chemo, less toxicity will be there. You just immunosuppress the host so that it can accept the donor cells and later on develop tolerance. And it can be used in older patients, but can be used in younger patients who are very sick and cannot tolerate myeloablative conditioning, where a short mortality is there. So what there you can also use non-myeloablative conditioning, and we can then go for a second transplant if the patient is not able to sustain the engraftment, because chances of graft failure are more with non-myeloablative conditioning. Just to tell what are these conditioning, in myeloablative, it's kind of just you remove everything from the roots, like you are preparing field. So you are preparing your bone marrow, you are removing each and everything of the past crop. So, and then it will cause irreversible bone marrow function. If you don't sow seeds, there will be no for the new crop. Okay. And in non-myeloablative, you are just trimming. So donor hematopoiesis is there, and you are giving, you are just sowing seeds of kind of recipient hematopoiesis is there, and donor hematopoiesis will also start, and it will depend upon whosoever takes upper hand. There might be rejection, or there might be ultimately a condition in T cells present in the donor graft. They might overcome the immune system of recipient, and then wipe off the donor hematopoiesis, and then can engraft. Or if there is a poor graft function, you can again collect donor lymphocytes and then infuse again to the recipient, and then further, the engraftment is enhanced when you use lymphocyte. As I told you, T cells are required for, because T cells will, kill the recipient's hematopoietic tissues. And in between is somewhere in between the two is reduced intensity, where there is less graft versus host disease. The chimerism, I will tell you what is chimerism. It will be mixed, it will not be full. For a transplant to be successful, we have to have full donor chimerism. Means all cell hematopoiesis should be of donor hematopoietic cells origin. In mixed chimerism, there would be both both donor and recipient hematopoiesis will be there, and the graft loss can happen either in reduced intensity or non-myeloablative. Just to give you an idea, you need not know what kind of regimens and what agents which we use for them. So the D day, basically the transplant day, the so much of hype has been done. We do for selecting donor, doing pre-transplant work, and ultimately transplant is just like a glorified blood transfusion. But it is done in aseptic condition, and for autologous we need to have around 2 to 5 million per kg of recipient's weight to have good engraftment. And for allogenic transplant patient also, the lower limit is 2. Anything less than 2 will the number of hematopoietic stem cell, if it is less than 2 million, the chances of graft failure is very high, or there will be poor graft functioning, which ultimately lead to graft rejection. So you need to have an adequate. So cutoff for auto is 2 to 5, LO is 2 to 7, and if you are using cord blood, so there the count used there is basically nucleated cells, total nucleated cells. So it has to be more than 3 into 10 to the power of 7 nucleated cell per kg of the patient's. So you can understand if a patient is an adult, and small amount of volume of cord blood may not be sufficient for them. So it's just we given just like a blood transfusion through central line as fast as possible in case of allogenic transplant, as if possible freshly. If you have collected and you just give pre-medication just with paracetamol or antihistaminic, and you transfuse within 10-15 minutes depending upon the volume, or as fast as possible depending on the tolerability of patient. But if you are using cryopreserved product, dimethyl sulfoxide, which is used as a cryoprotectant, has its toxic effect. So there you have to go slightly slow. So you can give that product over 30 minutes or 1 hour or so. Okay? But the moment you thaw, you have to start immediately transfusing the product, because minute by minute the viability of stem cell gets affected. So the moment you bring the product thoughts, you start transfusing. And you can, if the product is more than 200-300 ml, so then you have to be slow. So you can give it over 1 or 2, or if you have 2 bags, you can give 1 in the morning, 1 in the evening, or depending upon patient's tolerability. You can give another bag next day also if the volume is very large, 600, 700 ml, 2 bags if you are having 350, 50 each also. Just in a nutshell, what happens is, this is patient's hematopoiesis before we start conditioning, and you give conditioning chemotherapy. Donor hematopoiesis declines, and your counts reach nadir, maybe zero. At that point of time, you infuse a stem cell, and it takes those stem cells some time to reach bone marrow, home in, and start proliferating and differentiating. On an average, 2 to 3 weeks. After 2 to 3 weeks, we can see some evidence of hematopoiesis of donor region. In case of autologous, a patient's hematopoiesis will restart. In case of allogeneic, donors' hematopoiesis start making appearance in the peripheral blood, right, by showing increase in neutrophil counts and platelet counts. And by during this time, because donor hematopoiesis, I think even T cells or immune cells also will start increasing. So to prevent from graft versus host disease, we start this immunosuppression, so that this kind of, this is one conditioning regimen example. We use many other agents for prevention of prophylactic graft versus host disease, like cyclosporin, mycophenolate, sirolimus, etc. So this is started from a day or two prior to infusion, or from the day of infusion. Most of the time, it is started 1 or 2 days prior to infusion of stem cells, because to make so that a steady state level of that particular drug is maintained. So that's why we started early. So the graft usually is composed mainly of some cells which do not have a proliferative potential, like mature neutrophils and all. They will not proliferate. They will form only debris. The ones which have some proliferative potential is, one is CD3. When it comes in memory cell kind of cells, when it comes in contact with some foreign antigen, they will start proliferating. So the cells which are of proliferative potential and contained in the graft are the CD34 and 3, and this has the maximum proliferative capacity. So initially, during first few weeks, or maybe first 3 months or so, the CD34 cells, which mainly is basically polarized towards producing myeloid series of cells. So that is why engraftment we take into the context of neutrophil count and platelet count. And lymphoid series takes time to engraft, so it's slow to rise. Lymphocyte counts increase very slowly. It is initially granulocytes and all. So B cell and T cells, they keep on, these immune cells, they keep on rising over the few months or so. It takes at least 2 to 3 years to reach a full immunological potential, basically in terms of lymphocytic series. Myeloid engraftment occurs very early, within 2-3 weeks. So it is very interesting to know what happens to this stem cell. We are infusing these stem cells through veins. There are studies where patient have stem cells. They have been directly infused into the bone marrow also. That can be used basically for cord blood or kind of cells also. But majority of the time, even bone marrow harvest and the peripheral blood harvest is given through central lines. So what happens is, through central circulation, it will reach into the pulmonary circulation, and from there, pulmonary circulation, it will come to the left side of heart, and from there, it will circulate through vessels and go into the bone marrow. And then those stem cells will find their niche, and they will home there and then start self-replicating and differentiation. And whole of this process can take 2 to 3 weeks. Okay, and not all the cells which we have infused will able to reach there. Some of them will just get filtered here and will die there, or they may get de-differentiated into the stem cell of that organ, depending on if there is enough stimulus to differentiate into lung stem cell also. So, and some will die, some will not remain viable, some will not be viable. So hardly 1 or 2% of the stem cells which we have infused will go and find their way in bone marrow. And since they have a self-replication and differentiation properties, so even those 1 to 2% of the infused cells will be able to repopulate the bone marrow within a matter of weeks. So just what happens is when you give CD34 cells, when they reach bone marrow niche, and when they come into the contact with blood and bone marrow endothelium or through blood vessels endothelium, they will just cause increased expression of integrin, which will hold the stem cell there. These blood vessels of bone. These are blood vessels of bone marrow. So they will then arrest the movement of the stem cell further, and from there, in between the gaps between the endothelial cells, this will move into the bone marrow and go to the niche, and then will start proliferating. So this is the way the stem cells which we have infused through the circular venous system will go and find their way, and they will just proliferate there and then repopulate the bone marrow. So engraftment is, as I've told you, it is the myeloid series which get neutrophils and platelets which start increasing, and based on the counts, we can say the patient is engrafting. So when absolute neutrophil count is more than 500 on 3 consecutive days, so the first day when ANC was 500 or more than 500, maybe straight away from 300 it has gone into 700, and next day it is 1000, and next day it is 2000. So the day it was 700, from 300 to 700, it is more than 500. That day will be taken as a day of neutrophilic engraftment. So it may happen on day 10 also, it may happen on day 15, day 17 also. And similarly for platelet engraftment, if the platelet count is more than 20,000 without giving any SDAP or RDP as support for at least 7 days, because if you transfuse SDAP on 18,000, next day you will find platelet count of 70,000, next day it is 50,000, next day it is 20,000, but for 7 days it is not sustained and it will go back to 18 or 15. So that means that patient has not engrafted. So if you have given SDAP and for next 7 days patient does not require any platelet transfusion, and patient's platelet count remains above 20,000, then the first day when the count was more than 20,000 is taken as day of platelet engraftment. So as you see, after stem cell or harvest or graft infusion, you see this is the neutrophil or myeloid series, which is the fastest one to recover, and you can see this lymphocytes. The most important one is CD4 T helper cell. It will take such a long months or years post transplant to reach a normal limit. This purple and brown lines are basically, this is upper limit, lower limit. So within normal, to reach normal limits of each cell counts, lymphoid cells take a longer time, as I've told you, but myeloid series within weeks or days, you can see their counts rising. And it is also seen in non-myeloablative, because some of the donors hematopoiesis is still occurring, so that their counts will not go reach another like 0 or so. They can have 300, 500, and again they can start rising. Whereas if you have used myeloablative conditioning for days together, absolute neutrophil count will remain 0, and then it will slowly start rising. The counts will start rising. Okay. So during this period, patient will require, till the engraftment is there, will require lots of supportive care in the form of blood transfusion, platelet transfusion, or you use prophylactic antimicrobials if the patient is not having febrile neutropenia, because I've shown you that cells may be the absolute neutrophil count may remain 0 for 10 days, 11 days, 7 days. So during that time, you have to follow all neutropenic precautions like hand washing and all, and you give prophylactic antimicrobials like Ceftriaxone, acyclovir, antifungals. And if there is a breakthrough infection, and you have to immediately start IV broad spectrum antibiotics. And during pre-transplant workup, if we find that the patient was already hypogammaglobulinic, we might give IVIG to the patient when the patient is having febrile neutropenia, or if your B cells, whatever remaining B cells which will be able to produce antibodies, they are also ablated. So you can give 2 to 3 weekly IVIG if pre-transplant also immunoglobulin profile was showing that low immunoglobulin levels. Now this is the term chimerism which I said, like before transplant. These are donor hematopoiesis, basically DNA. This is done after using DNAs use DNA and using RT-PCR and all. So this is of recipient origin. You give transfuse donors cells, donor DNA will come here, and then there will be brief period where both type of hematopoiesis will be happening. And if you do check for chimerism through RT-PCR, you might find both kind of DNAs. And over the period of time, when there is a full donor engraftment, your all recipient hematopoiesis will be abolished. You will find only hematopoiesis of donor origin. Then you call it as full chimerism. So what we want is basically full donor chimerism in cases of allogenic transplant. And this is, like if you see, this is donors. This is done through various. There are kind of different softwares and all. So these are donor origin RT-PCR peaks, and these are recipient. So this is before transplant. This is before transplant. Yeah, this is donation. So after transplant, then you do it. Then you see there are some peak of recipients DNA and donors. This is mixed chimerism. And over the period, we want all this to this recipient origin DNA to disappear. Hematopoiesis to disappear, and we want it to be like that only of donor. So we should be finding only these 2 peaks of donor origin. Then we'll call it as a full chimerism. So coming to the complication, you can have complication pre and post. Pre is transplant because of conditioning regimen. So mucositis is the most common complication, because this chemotherapy basically acts on rapidly dividing cells, and the tissues, there are only 3-4 tissues in the body which are dividing very rapidly and will get affected under the effect of chemotherapy. One is your bone marrow itself. So we are giving chemotherapy to ablate bone marrow, but in that process, bystanders are other tissues which are also proliferating almost similar to the rate as the bone marrow cells are proliferating. The cells which are basically of lining of GIT, and mucositis. It can be oral mucositis, it can be pharyngeal mucositis, or it could be esophageal, stomach, or intestinal mucositis, which may be manifesting depending upon where the mucositis is happening. If it is happening in oral cavity, patient will not be able to swallow, will not be able to swallow even his saliva. Sometimes the patient will keep on drooling. If it is in esophageal, the patient will have problem in swallowing, and if it is of gut, you can have diarrhea, pain, abdominal also. And because there are no neutrophils and all, there are multiple factors which can lead to the predisposition toward infection. And the most common infection which we encounter are basically bloodstream infection through various organisms, skin infections, perineal infections, gut infections, and all, pneumonias also, and all kind, virus, bacteria, fungal, all will gain entry into the body, even if they are opportunistic. In some of them are opportunistic also. And if the patient is CMV positive, so there may be latent CMV viral particles residing in any of the tissue, and they will get reactivated and cause CMV disease. It's just give an example. So depending upon the post-transplant phase, there are a specific kind of infection which you can predict and be prepared for that. So before engraftment happens, so by virtue of neutropenia, mucositis, and the use of centrifugal access, use of central lines and all, so there is breach in various barrier. So these are the commonest organism: gram-negative, gram-bacilli, gram-positive organism, which will cause febrile neutropenia, and neutrophils are not there to fight these infections. Like the most common viral infection is HSV, which we already give prophylaxis for that using acyclovir. And the other different viral infections can also happen, but to the less extent during initial phase. Fungus, till the neutrophil counts is high, fungal infection can happen in early transplant, early pre-engraftment phase. And once there is an engraftment, since now you have, neutrophils to combat the infection due to bacterial, it is viral infection and bacterial fungal infection where you also need T cell and humoral immunity to counter those infections. So these the cytomegalovirus infection starts getting activated after post-engraftment. So we monitor this copy number. Even EB virus also start getting activated, and it can cause post-transplant lymphoproliferative disorder. And for countering fungal infection, you need neutrophils as well as humoral T cells also to fight intracellular organism also. So fungal infections can happen in any phase of period. And as the post-transplant period progresses, the functional asthenia is still there. So infections with encapsulated bacteria are common. So once the patient is off immunosuppression, we start immunizing these patients, like with pneumococcal vaccine, hip vaccine and all, to prevent infection through these encapsulated bacteria. And we give varicella zoster vaccine also once immunosuppression is off. Gradually we just follow, we re-immunize the patient now, because patient has acquired a new immune system, and which is new because all the T cells, B cells would be naive. They have not encountered those antigen or infective agents when we use hematopoietic stem cell, because all the cells will be of naive origin. So then we have to re-immunize those cells. Hemorrhagic cystitis is a complication of basically conditioning regimen, or sometimes it is as a result of viral infection. And it may present as asymptomatic hematuria, just patient will complain of that red passing of radiation, or it may progress up to very severe painful condition where patient would require IV analgesics, continuous bladder irrigation and hydration so that clots doesn't form. If the clot forms, then there will be urinary retention, it will be more painful. So this can happen in basically if those patients who have received cyclophosphamide or TBI based conditioning. So we are always on lookout for this complication. And if there are viral infection, we also work, any patient who is having hemorrhagic cystitis, we also work up for viruses, and we can use antivirals like cidofovir, etc. If hemorrhagic cystitis is because of conditioning drugs, it happens during early immediately post-conditioning early phase of transplant. And if it is because of infection, as you have showed you the timeline, these because of hemorrhagic cystitis, because of viral infection can come. It happens later during post-transplant period. The other thing is engraftment syndrome. Most of the time it is not harmless. It happens due to cytokine released, a cytokine storm, which happens when you neutrophil start engrafting and releases lots of cytokines, which can cause increased permeability. So you can see erythema and all, and you can see the weight gain because of capillary permeability increases. There may be neutrophilic infiltration in the lungs and can cause hypoxia, and very rarely hypotension kind of thing. That is only when it becomes life endangering, then you use steroids, or sometimes you require tocilizumab to control engraftment. Most of them, in 80% of time, it is just a transient phenomena. We just keep watch. We just keep the patient dry using diuretics And if there are diarrhea, you just maintain the hydration and all. And gradually it subsides within a period of 3 to 4 weeks and may sometimes last for 7 to 10 days also. It is only when the patient develops hypoxia or hypotension that we need to intervene using steroids or inotropic support or to IL-6 inhibitors, tocilizumab, etc. Another dreaded complication is Phenoclosive disease. What happens is it is basically because of endothelial damage under the effect of conditioning regimen. This is basically to just to make you understand the pathogenesis of Phenoclosive disease. These are the sinusoids in the liver. This is normal liver architecture, and these are the sinusoids. So, these are lined by the sinusoid little epithelial cells, and they have some Cooper cells and RBCs. Under the effect of conditioning regimen, the endothelial lining of sinusoids it gets damaged, and it can clot and can block the sinusoids. So now, if there is no blockage, there is smooth flow. The blood flow is in hepatic sinusoid is basically through portal vein and hepatic artery, and after that, then blood is collected through hepatic venules and goes to hepatic vein, then IVC, and then goes into heart. So if this get blocked, so what will happen is there will be no blood flow in the hepatic veins. The size and caliber of these veins will reduce. Taken almost, they will get occluded. With the debris also, they can get occluded. But what will happen is there will be a back pressure and there will be congestion. You can see here, RBCs will get congested because they are not flowing into hepatic circulation or systemic circulation. And there will be reversal of flow in portal vein also. And this hepatic artery will show dilation. And all these can be assessed using imaging techniques, ultrasound or MRI or MRNG. Or sometimes some people have used recently PET scan also, because in PET scan, what will you see? There will be hepatic blood pool collection, so their intensity will be higher than what is normally seen. So that they can get an idea. But what we resort to is basically ultrasound, which can show the dilatation and all. Sometimes ultrasound Doppler, which can show the reversal of blood flow. And it is clinically identified by because there will be blockage and there will be then damage of the hepatocytes. You will have hyperbilirubinemia, weight gain, and because of congestion, there will be tender hepatomegaly. Even if you are not able to confirm using imaging technique, it is a clinical criteria. On the basis of clinical criteria, you can start acting. Most of the time, again, majority of the time, it is self-limiting, but then you need to use, if it is progressing towards severe the severity is progressing, then you initially use diuretics and all, and then if it is not working, then you can use defibrotide also, and it is very costly, and you have to import that drug. It's cost in lakhs. Okay, so you have to initially decide when you are assessing patient for transplant. So what kind of chemotherapy patient has received, what kind of monoclonal antibodies which can predispose to Phenoclosive disease. So we would be better prepared for VODs. So cyclophosphamide, busulfan, inotuzumab, these are the agents if the recipient has already received. So we are on our guards that this patient will have Phenoclosive disease. If the money is no constraints, then you can use defibrotide as prophylaxis. Otherwise, you can use defibrotide if the patient has severe VOD, because the mortality in severe VOD is around to 80%. Then you can use defibrotide for treatment purposes also. And for prevention, people have seen the use of ursodeoxycholic acid. And some people have used NAC, and they have found some good result in preventing VODs. And some people have used amifostine. There are multiple agent, pentamidine, and some and heparin kind of thing. People have tried to use to see, to ameliorate this complication. But if it has to happen, it will happen. So you have to be better prepared for that. Another unique complication for transplant is basically once the donor hematopoiesis starts happening, and there is already some residual kind of host hematopoiesis, and if the stem cell dose was less, So donor hematopoiesis is not up to the mark, then host hematopoiesis will increase, and it will cause a rejection of graft. It will take the upper hand. And if the stem cell dose was high but the T cell dose was very high in that, then you can have graft versus host disease. But a controlled kind of graft versus host disease gives a benefit of graft versus leukemias effect, because leukemic cells are of host origin, they will be also showing those antigens which are of host origin, and the immune cells of donors, they will identify those leukemic cells as foreign, and they will kill those tumor cells also. So the added benefit of graft versus host disease, if it is limited grade 1 to 2, is, especially in cases of malignancy, is graft versus leukemia effect. And in case of non-myeloablative or reduced intensity conditioning, gradually, if there we need to give very high count of hematopoietic stem cell, so that we have a good T cell reconstitution, and those T cells will now they can also fight against cancer cells. So in those non-myeloablative and reconditioning, we take advantage of limited graft versus host disease, which can also provide us graft versus malignancy effect. So you give conditioning to make host more receptible to the incoming stem cells, but then this recipient becomes bilkul defenseless, but they are ready, because we have given conditioning, they are ready to accept. But once the donor hematopoiesis, which has been now which has now going to the new bone marrow environment, and when it starts proliferating and goes into circulation and goes to various organs, there it will find it as a foreign, especially like in skin, liver, gastro, those gastrointestinal tract, lungs, or other tissues. It will find the immune cells of the donor hematopoietic system will find that these are having though they are HLA matched, but there are certain other factors which can also tell the donor if it is fully matched, like minor histocompatibility agent, which we do not test for, and they will identify it as a foreign, and will start graft versus host disease. And in case of haploidentical transplant and all, obviously there are only half mesh, so then you give lots of immunosuppression so that it doesn't cause graft versus host disease. So the commonest organ which are involved in acute graft versus host disease are basically intestine, liver, skin, and those who have worked in transplant with us will remember you can have all kinds of things. For upper GI graft versus host disease, we go do endoscopy. Upper, or for lower endoscopy, sigmoidoscopy and all. And if lower GIT is involved, you have diarrhea, we just measure the volume and can identify that this patient is having GVHD. And all this happen actually once the patient engrafts. And liver GVHD is manifest in the form of jaundice, transaminases, skin, depending upon erythema, and extreme degree you can have bulla, just like burns and all. Depending on the percentage of skin involvement, you can classify what is stage 1, 2, 3. So the acute GVHD is more common seen with BPSC as compared to the bone marrow. Just to show this graph. So I have just told you about the various complications which can happen during transplant, and we are geared to tackle them. Most of the time we are able to tide over all those problems, but sometimes the things can go out of hand and we may not be able to save patients. So in case for preventing host versus graft disease, we give immunosuppressants so that recipient is able to accept the incoming graft. And for graft versus host disease, then we have to increase the immunosuppression so that we suppress the immune system of donor fighting against the host. And during Grafton Syndrome, again, you monitor, give diuretics or steroids, similar for Phenoclosive. I've told you for febrile neutropenia, we told you prophylactic and therapeutic antimicrobials. And for checking for the reactivation of viral, we send viral copy numbers weekly. And if we find it is rapidly rising, we institute antiviral therapy. For CMV, we give ganciclovir, and for EBV, we use rituximab. And if EBV has progressed to cause post-transplant lymphoproliferative disease, we might resort to giving chemotherapy. Most of the time, it is lymphoma DLBCL type, so there we give R-CHOP kind of therapy. Chronic graft-versus disease mainly affects skin, like in 80% of cases, and oral, liver, pulmonary, myofascial, eye. These are common chronic GVHD, but they are not life-threatening, and we continue giving immunosuppression. We tailor immunosuppression depending upon the severity. So there are many patients who are on immunosuppression for past 5-6 years also. But then chronic GVHD basically is not life-threatening, but because of immunosuppression, they might contract infection, and those infections might prove to be fatal in them. And the quality of life also, because of these kind of disfigurement and all cosmetic effects, the patients are confined to their home. But in many patients, everything can also get normalized, which I will show you in further slides also. So this is one patient of AML, underwent haploidentical transplant, GVHD, and then gradually his skin GVHD is improving. Still some amount is there, but then it's improved. And now you can see this patient. You cannot identify. It's this nice looking young boy. He's now 22 years. So the late effects are basically as a result of conditioning regimen. And the most common late effects which we monitor are endocrinopathy. So basically pituitary hypothalamic excess is involved. Hypothyroidism is one of the commonest hormone deficiency which we encounter. Because of sex hormone deficiencies, your bones become fragile. You can have doing DEXA scan, you can know the patient is osteoporotic, and you have to treat that. And infertility is another issue. And the other thing, late effects, maybe because sometimes so much of GVHD is there, and we keep on increasing the immunosuppression, and if sometimes balance may tilt towards that, all of the donor hematopoiesis gets affected and patient might relapse. Or even if the immunosuppression is that, there are some clones which can, especially in acute leukemias, and that too in ALS, there might be a late relapse after 2-3 years. So up to 2-3 years, we are, keeping our fingers crossed for any evidence of relapse. And there can be second malignancy. There can be relapse of the initial malignancy, and there can be second malignancies also. Is basically they are squamous cell carcinoma kind of skin or oral cavity. There can be pulmonary damage and cardiac damage, so we monitor, or kidney damage, so we monitor with PFTs. And if we find evidence of pulmonary toxicity, if it is because of GVHD, we manage through various inhaler and all, or sometimes we just give symptomatic treatment. Patient can live with some kind of, and they have to be under care of a transplant physician. So the other complications are basically, which we commonly see, is cataract or dry eye, dry oral cavity and all. And we accordingly manage those patients with artificial tears or artificial saliva, and replace hormones depending upon what sex hormones or thyroid hormones are deficient. So the mortality is somewhere to the tune of 20 to 30, 15 to 20%, and it is now gradually decreasing, and it is now, in some center it is only 10%. In our center it is around somewhere around 15 to 18%. So on an average, 20% is the mortality, which if combined, if you all centers, you can say. So, and the most common cause for death after transplant in cases of allogenic transplant is, in cases of autologous transplant, is relapse. Other organ toxicity, infection, they are very less cause of transplant. The most common cause of deaths in autologous transplant in lymphoma, myeloma is relapse. And that too refractory relapse, not responding to immune salvage or second transplant also, they can again not be, the condition may not get under control. In cases of allogenic transplant, if it is a mass sibling donor transplant, relapse, mass sibling or unrelated, almost same incidence of causes of death. Relapse in 1/3 of cases, graft versus host disease in maybe 15% of cases, infection obviously around 15 to 20% times is the cause of death. So the most common cause of death in acute phase is basically infections followed by graft versus host disease, and in late causes of death is basically relapses. So the other thing which we have to discuss with the family is financial aspect. In autologous transplant, because the complications are less, mortality is less, the cost is somewhere between 2 to 7 lakhs. Multiple myeloma, like maybe up to 2 lakh. Sometimes in one or two patients, they have just incurred cost of only 1.5 lakhs. It is mainly the allogenic transplant where the complications are so much. So to manage those complications, the cost goes high. So in matched related donor transplant, cost is somewhere between 10 to 15 lakhs over 1 year. This cost is over 1 year, not over 1.5 months till the patient is hospitalized. This cost is over 1 year. And if we are going for a mud transplant, because the registries, they have their own charges. Some registries charge 20 lakhs for stem cells, some registries charge 10 lakhs. So depending upon that, so the cost of mud transplant can be around 30 to 40. It can go if the mud transplant patient develops complications, severe complications, then cost can go up to 60 or 70 lakhs also. So in nutshell, when we are planning for a transplant, so we have to see fitness of the donor, recipients, availability of the donor. We have to evaluate whether the patient will be able to tolerate transplant or not. If they are not, even if the patient is having full matched donor, or if the patient doesn't have any financial issues, we cannot straight away take the patient. We have to, first see that we do not do any more harm than the intended, which is inherent to the transplant process. If we know the chances of cure are not there, unnecessarily doing transplant is not, advisable. Okay? And once you explain, it is the willingness of the family and the recipient. If we tell, when we are counseling, some may get very, demotivated, understanding the complications and all and the cost. It is up to them, but it is not that if we want to transplant, we will not tell the complications and outcomes. We have to be very honest with them, and it is the shared decision between us and the family to go ahead with the transplant. So this was the youngest patient of SCID we transplanted at age of 3.5 months, which is the ideal age. If they transplanted before 3.5 months, the outcomes are very good. He is now 5-year-old, kicking, healthy. It's going to class. He's going to nursery. And this was a thalassemia transplant, transplanted at 3 years. Donor was sibling sister, full match donor. Bone marrow harvesting was done for this from the donor for this transplant, and he's now 4.5 years. This is the reason he studies in class first, and this was the donor who was 7 years at that time, and the patient was 3 years. Now the donor is, I think, 10, 11 years. This was one relapse Hodgkin's lymphoma, transplanted at 15 years. Now he's 26-year-old, joined US Army. This picture I like very much. This was the patient. She was 21 or 22-year-old, severe aplastic anemia. We transplanted, and 4 years after transplant, you can see her fertility is maintained. And this is 2-year-old daughter, and now she's planning for second pregnancy also. So not everything is very disheartening. There are so many things which keep us motivating, and we can, encourage patients where we know only the transplant is the curative option, understanding the risk, and if the family is able to take risk, and we should go for transplant condition. These are other patients, leukemias, lymphomas, and all. So to sum up, in cases of which is the we use peripheral blood stem cell mobilization for our transplant in we'll say 99% of cases. Only in 1% of cases we do bone marrow harvesting, and we don't do cord blood transplant here. And after mobilization with GCSF, you do apheresis, graft, and then you transfuse. Donor hematopoiesis, recipient hematopoiesis goes down, donor hematopoiesis take over. Okay, and the patient is discharged once engraftment is there. So I finish here. If you want to understand anything or you want to ask anything, you're most welcome.